Good morning, good afternoon. Welcome to the next edition of the Voices of Value podcast on LinkedIn Live. I'm Andy Day, Chief Marketing Officer at Lightbeam Health Solutions, a pioneer and thought leader in population health management, enterprise software, and artificial intelligence. And it is my honor to host this just launched podcast that we have named Voices of Value. Voices of Value aspires to be a narrative and a dialogue on the value delivered to patients like us from technology innovation in the healthcare and life sciences industry with a focus on, but not limited to AI and analytics. We will livecast Voices of Value on LinkedIn Live as a primary channel of engagement, but we'll also syndicate these valuable conversations with industry luminaries and thought leaders through other channels like YouTube, the Lightbeam blog, Facebook, Twitter, etc. So in this second session, I have the honor of presenting, continuing with my outside-in perspective on the art of the possible with AI in healthcare, and also talk specifically about population health management that will cut through the hype, the noise, and the confusion on AI in healthcare. Going forward, we'll adopt a 25 to 30-minute fireside chat format in which I'll have the privilege of discussing relevant and salient challenges in healthcare, life sciences, population health management, care management, and how innovation in AI and analytics is addressing these challenges to deliver value. Voices of Value will be brought to you monthly via LinkedIn Live, and we strongly encourage you to follow the Lightbeam Health LinkedIn page as well as our web pages to stay abreast of these discussions that will inform your innovation strategy and execution. So let's continue with the conversation we had. So here's a fundamental challenge that is afflicting the healthcare and life sciences industry. If you ask everyone, what exactly is artificial intelligence, just because of the disproportionate hype and, VC investments, the fear of missing out, you'll have most people say that it's generative AI, which couldn't be further from the truth. So artificial intelligence is actually a portfolio of various technologies or modalities, which actually have been around for a long time. The first of which is machine learning, which uses, statistical algorithms to recognize patterns and learn from the data to be able to predict what is likely to happen. Deep learning is a subset of machine learning, which looks at unstructured data and can use it to simulate responses or answers similar to the working of the human brain. Natural language processing and natural language generation basically, converts data into text, simple, query into common, language that can be understood by folks. That could be someone on the manufacturing shop floor or a nurse at the patient bedside, and understand what are the key takeaways from patient's chart, for instance. Generative AI LLMs, obviously, I bet this is what you've been hearing the most about. This is what has attracted the most hype and investments from VCs for the largest number of startups, driven by what are called large language models, which are very large models with billions of parameters, which operate on a query response kind of a paradigm and will return responses. We'll delve into this a little more in detail. The new kid on the block, which I think candidly is the most promising, is agentic AI. Think of agentic AI as an operating system for AI agents, which can be used to automate workflows, tasks, and processes, has the most significant potential in terms of output, but also would present challenges in terms of actually replacing lower level jobs performed by humans today. Not conventionally talked about within the healthcare realm is medical robotics. So for instance, the Da Vinci robot from Intuitive Surgical, which is used to perform, operations for surgeries for prostate cancer, for instance, which actually involves other technologies as well, like machine vision, which enables a doctor to actually see the patient and what he's doing, as well as augmented reality and virtual reality, which is increasingly finding its way. So, what are some of the key considerations? Starting Most companies or CXOs start with the question of help me define my AI strategy and which AI should I work on. And that's absolutely the wrong, way to go about it. Really look at where are your challenges? Where would robotic augmentation or AI augmentation or automation really deliver and increase efficiency, productivity, reduce burnout and drive, higher capacity. Look at the use cases with the highest value and ROI. Look at your competencies in terms of do you need to build this or buy it from vendors like, platform as a service vendors or consultancies or SI vendors that will help you do it. What is your risk-based approach, in terms of transparency? We're talking about explainable AI versus black box. And of course, governance oversight, AI ethics and compliance is a significant area of opportunity. So, as I mentioned, generative AI, which uses this query response model based on a large language model, has significant challenges. The first of which is hallucinations, right? It is going to query a lot of really uncurated data and therefore return answers which are not necessarily accurate. And despite significant advances in generative AI models, the hallucinations are getting even better, but the fact remains that it's still hallucinating, which presents a challenge in a healthcare clinical context. Given that it is drawing data from resources which may have intrinsic bias, the AI, displays bias as well. Non-determinism, if you run the same query 5 times, chances are it'll come up with 3 different answers, which is definitely unacceptable in a healthcare context. This is a significant security challenge. The ability to manipulate the Gen AI via prompt engineering, which is being called AI grooming, and of course, copyright infringement, given that it's scanning data from a lot of copyrighted, trademarked, data is a challenge. So this is limiting the number of use cases and applications, given the disproportionate investment in Gen AI. But what is happening is Gen AI, in my humble opinion, is going to be subsumed by agentic AI, which is on the right, which is not just a query response model, but you can actually use to evaluate and fix some of the hallucinations from the underlying LLM models. In this case, best practice is to use curated, SLMs, which are small language models or large language models, evaluate what the responses are, and then use the non-hallucinated input, if you will, output to drive automation of tasks, workflows, and processes. Here is a four-stage AI innovation adoption maturity life cycle, with time on the x-axis and the potential value ROI and payback from AI on the y-axis. These are, guesstimates. This is a framework I've crafted, which is, I think a very useful way as you embark on your AI strategy. At the lowest level, this is where probably 50 to 60% of folks embarking on AI are, which is augmentation, which is look at your repetitive queries, tasks, workflows being done by enterprise SaaS software today, and analytics, and augment it with machine learning, natural language processing for self-service, right? So examples could be conversational AI powered chatbots for customer self-service or physician scribes, which take down physician notes during an encounter automatically. AI prescriptive actioning, you'll see this also being referred to as anticipatory AI. I think prescriptive actioning is a more appropriate description, which is this transition from descriptive and predictive to prescriptive analysis with recommendations for specific actions to be taken by a nurse, a care manager, a physician, a customer service rep, for instance. So, for example, prescriptive care gaps or care orchestration, which we'll discuss in some detail. AI automation, this is really the arena where agentic AI enabled by LLMs and Gen AI is going to play a big role. This is where literally all of the innovation is happening, which is automation of manual, repetitive, and error-prone tasks and workflows with automated exception detection and resolution. Currently with human intervention, but eventually you could do this with minimal human intervention. So great examples of this is ambient listening, which is the generative AI use case that has seen significant deployment, automated ordering of drugs and supplies in a supply chain context when they hit min-max thresholds in a hospital. And then the holy grail is really the notion of autonomous AI, which is also being called artificial general intelligence. It is also sometimes referred to as singularity, which is AI systems capable of performing, they're so good at automation, they can perform tasks and make decisions aware of the environment and the ecosystem independently without constant or any human intervention, and adapting their actions based on the outcomes. I think the classic example of this, which is happening, is self-driving cars. And one would scratch one's head, right, given that healthcare is in the business of saving lives. But I think the one which is likely to happen is this notion of an AI radiologist that scans, thousands of DICOM images and can spot, the outliers that demand intervention, that should be escalated for a radiologist to quickly look at it and then passed on to a neurologist or an interventional cardiologist if there is a risk of an acute event like a heart failure or heart attack or a stroke. So good question. Use this framework if you're in the audience, and good question to ask: where is your healthcare adoption organization on this AI adoption maturity life cycle? We as vendors obviously want, we are working on driving our solutions through this framework as well. So that is what I'll transition to talk about: how Lightbeam Health is impacting the population health management arena through some of these technologies. So this is our approach. We are an award-winning AI platform with, we enhance outcomes-driven population health management without the hallucinations. We are very, very careful that the technology we use uses curated data with guardrails and ensures that we can empower healthcare organizations with prescriptive insights. Stage 2 that we talked about, automated workflows. Stage 3, sense and respond capabilities to enable superior patient outcomes at a lower caregiver fatigue and cost of care. This is basically our solution footprint laid out. Really, our data orchestration platform, which captures data from claims, ADTs, EHRs, HIEs. It blends and preps and normalizes the data, and that is then used to drive AI-driven analysis, right? Risk stratification, HCC insights, etc., identify care gaps, workflow automation, which then empowers physicians, care managers, care coordinators to identify high risk and rising risk patients, put them through the care management programs to ensure that they do not, it lowers your risk of admissions, readmissions into the ED, and ensures that you basically not only drive higher patient outcomes, but you do so with avoidable cost, with avoiding costs, unnecessary cost, which in turn results in hopefully better value-based care outcomes. So predictive AI insights to identify high-risk, rising risk patients, prescriptive AI insights telling the care managers precisely the care gaps that need to be filled for a certain high risk or rising risk patients. And then through our deviceless remote patient monitoring solution, which uses AI to automate to enroll patients, which is call and text based, which makes it really inexpensive and easy to enroll thousands of patients. And it serves to increase a care manager's capacity almost 8 to 10 times, which, as you can imagine, drives significant ROI and payback. So the advantage here is not only are we using classic, clinical models for patient risk, but we are also combining that with SDOH, social determinants of health enabled by AI. So from a community perspective, we are looking at 4,500 social determinant of health factors, including the US Census Bureau, the Department of Agriculture, the Center of Disease Control and Prevention, but also looking at data at an individual level in terms of their propensity to buy, what do they do for a living, where do they live, are they in a food desert, for instance, how many people in the household, do they have appropriate, transport, what is their socioeconomic, status, if you will. So here's an example. So here is a patient who, a female patient, and she's identified standard clinical analysis would identify her for diabetes and depression. Now, with all of this additional data in terms of SDOH, the AI-enabled, risk analysis, we now add to that picture and recognize that not only is she a diabetic suffering from depression, but she has financial insecurity. She lives in a food desert, which means she is not getting the nutrition needed. She's not very technology savvy, she's a widow who lives alone and lacks social support, which, as you can imagine, increases her risk, significantly, that is otherwise not be captured. So, according to the National Institute of Medicine, for patients with similar disease burdens, this not knowing all of this additional SDOH risk contributes to 80% of the variability in clinical outcomes, which is driven by non-clinical factors like all of this SDOH issues that we just discussed. So Lightbeam offers, almost 15 AI-driven models which can be used to ensure that you get a 360-degree view of not only a high risk but rising risk patients who, if they are not taken care of, would run the risk of becoming high risk patient with acute events, like stroke, heart failure, heart attack, COPD, etc. So I won't go through all of these models, but we have models that can predict avoidable admissions in the next 30, 60, 90 days, avoidable admissions, members at the highest risk of avoidable ED visits in the next 30 to 60, 90 days, end of life support, and as we just mentioned, individual social determinants of health. The lady who's a widow with financial insecurity that we just talked about, and then also at a community level, right? Are folks living in an area with food insecurity, in a food desert, etc., which impacts their ability to take care of themselves as a community. So most models, we have obviously a number of vendors who offer these, and most of them would be able to aggregate the data from various sources and identify, risk of acute events, happening, avoidable ED, etc. But what, Lightbeam does differently is thanks to patent protected capabilities. For instance, we have a capability, an AI-driven capability, which we call ATI, or the ability to understand what is the ability for a patient, a high risk patient, to change behaviors such that he or she does not get to an ED for admissions or readmissions, and we can actually change that behavior with intervention, which serves to reduce readmissions, reduce care manager call time, identify more avoidable utilization events than electronic health records alone, which is why our customers use us with their EHR of choice, and drives cost savings running into millions of dollars. Sounds too good to be true. Let's look at a real example. This is a very large integrated delivery network in Arizona, which sought to increase the impact of their, limited care teams. You have care teams of 8 to 10, and they often have to, ideally look after hundreds, if not, and thousands of customers, which is a challenge. So how do you reduce avoidable admission? In this case, they're high risk Medicaid plan members, improve care coordination, and reduce risk. So in this case, they deployed Lightbeam is a 30-day avoidable admission AI model to proactively identify high-risk members who are at risk of an avoidable admission within the next 30 days and engage with them. So this is how the model worked. The AI model performed an assessment of the IDN's 140,000 Medicaid population members. It returned a listing of about 4,200 high-risk members that really needed attention and monitoring. However, given capacity constraints, the care managers did outreach to 150 of the 4,200 who are most at risk and most who potentially had the ability to be impacted. So this is a summary of the value and impact from this model. So as you can look on the chart on the left, 3% or actually 8% contributed to almost 53% of the cost, right? 8% of the highest, 3% contributed to the top, to 33% of risk, the highest risk patients. The ones in orange are rising risk. And driving that intervention with the 150 of the 4,200 who are most at risk lowered their risk of admission, the 30-day readmission rate, the 30-day admission rate by almost 43%, which resulted in a cost avoidance of $637,000, which, as you can imagine, more than paid for their investment in the Lightbeam AI-enabled care management solution and population risk stratification solution. So I'd like to conclude with this quote, which I think is very eloquent. AI will deliver value by unburdening clinicians and care managers and nurses and empowering them to focus on caring for their patients, which is really what they do best. But trust is key. Remember, we talked about explainable AI and black box versus transparency. So trust is key to the adoption of AI at scale, and AI will be deployed at the speed of trust. This is a quote from Dr. Stephen Jones, who is the CEO of Innova Health. And we have a great example of this in terms of Kaiser Permanente, which has just rolled out, uh, you know, which has just rolled out AI in the form of ambient listening to almost 22,000 physicians, and are potentially exploring whether it makes sense to do that with nurses as well. So I hope this was useful. The models, I hope, will inform your AI strategy. And would like to conclude by inviting you to visit us at Lightbeam Health. Please follow our Lightbeam LinkedIn page, where we'll promote all of these podcasts, so you know what is coming next. And really invite you to visit our revamped Lightbeam Beacon blog, where you'll see a lot of the thought leadership around AI, the AI innovation that we'll present in this podcast, presented as blog posts with the models, with the presentations that you can take advantage of. So thank you very much for your time today. We really appreciate your presence here. We look forward to engaging with you, answering the questions you have for us, and invite you to come back again. We are going to do this on a monthly basis, so please come and take advantage of this podcast, and also check out our blog for our latest blog post. Thank you. Have a great day and the rest of week ahead.